Okay, I think we're good.
Awesome.
Okay, so I think our first item is to talk about our favorite
Favorite
suture.
suture.
Have you guys done a lot of suturing? I do the baseball. That's generally all we do.
Yep, same. I've done the worm stitch before, but only one time. But generally speaking, we're baseball all the way. So
Yeah. What about
Yeah.
you, Kayla?
Typically, it is mainly baseball that I do. And honestly, I like it the best because I feel like I have more control over how tight I can get it to help prevent leakage versus doing the worm or anything else.
Yeah.
yeah, that's exactly why it's the preference for us too. Like if it's not going to show, or if you can wax it even, it's better to
hmm
get it tight.
When you did the worm, how did that work?
So it's funny because it was last semester and it was so I have five preceptors actually, because there's five directors at the funeral home that I work at. And so the owner, who's the oldest, is the only one who does the worm. Um, and so he talked me through it. So, I mean, it looked nice at the end. He does it. I mean, he's just so experienced and talented. So when he does it, it looks really nice. And when I
hmm
did it, it was like a cool, good shot, like nice
Yeah,
going.
Was your first time, that's why.
that's all right.
First and only.
Practice makes perfect.
Yeah, exactly. I'll tell you though, I did an autopsy case and there was a cranial I did all of the suturing for that. That was a couple of weeks ago. And of course this was a guy who shaved his head. And so, it's just like, oh, but luckily the ME had done the cut in the way that it wasn't going to show anyway, which was good. So I was able to use a baseball for that. But I was thinking like if they had not been as thoughtful, um, I would have maybe tried to use the worm or, another one that's less visible. As it was, I just put the stitches really close together and made them as tight as I could, so that it still looked nice, but yeah, his skin was so hard and thick that it was like I was afraid I was going to stab myself just trying to like get the needle through every single time was ridiculous.
A
Yeah.
younger person.
He was probably like 50-ish. He was like one of those like, like those like strong beefy dudes who like shaves his head,
Been out in the sun for years and just had that tan hide skin.
Yeah, and he embalmed really well. So that was a big part of it was that his skin was very hard from that. So
Wow,
yeah,
interesting.
yeah.
Yeah.
So baseball.
Yay. Yeah. Thank goodness for the originality.
Hmm.
Okay, how about instruments? What's everybody's favorite and why?
You want to go first?
My favorite would be different than the one that I use the most. My mo the instrument that I use the most would be my aneurysm hook because I use it for about everything. From raising vessels, placing eye caps, all of that stuff. But the one that I like using the most is my needle injector, just because there's just something so satisfying with doing a nice mouth closure. And the other methods kind of terrify me. So
Have you ever sutured?
I have not yet. I've seen it done and I'm like, oh boy. And the last time that we had to, my preceptor was with me and I was like, I can't get this mouth to close because the needle injector would not, the wires kept pulling out. And I was like, can you just do this quick? Because I was literally on a huge time constraint. And so I was unable to walk through it with her at that point in time. But otherwise, it's been since literally the very beginning since we've had to do it. So I think I watched her do it once then and then just this last time. But like I said, there was so much going on. We didn't have time for me to be walked through it this last time.
Yeah, I think I'm still terrified of the needle injector. I'm just, I don't know. I don't know why.
I find it so satisfying. It may make me a little bit of a weirdo, but that's okay.
Yeah, I think, well, so I haven't, my preceptor really didn't let me use it a lot. And I don't know if it was like, he's super awesome, but if he just didn't think I had the strength. And so the first time I did it, I turned around and I was like, ah, I told you I could do it. It's just that, like, I don't know, maybe the logistics of it. Like, you just got to keep going. Sometimes, but
Yeah, we don't suture at all. Like the directors where I work, they can always find some sound bone to put it in. But I've done it before, like with a super old guy, and he had his own teeth, but it just like the barbs kept pulling out like over and over again. I was like, oh my God, I'm just destroying this poor man's jawbone looking for a solid place to do it. Uh, yeah, so finally I turned it over to a preceptor. And also, for as disgusting as most people think this job is, people's mouths are what like pluck me out like retchings that like yeah. The only time that I've ever been like nauseated and had to like step away was somebody who was had been really sick and really dehydrated, so his mouth was just full of like white goo, like days worth, and it was just like yeah, so horrible. So um
I understand and agree with that. I went from nursing into this field too, but my ick is I cannot, the mouth just, I love closing a mouth, I'm fine. But I was on a case that my preceptor had actually like there was a broken tooth and it was on the tongue and I literally just instantly started gagging. I do not do loose teeth or anything like that. So
mhm. Um, so my favorite instrument, I think I said this last semester when we did the embalming podcast with tissue separator. I love that thing. So,
oh yeah.
because like raising vessels, there's just so much stuff in there. So to be able to like be able to like see it and feel it, like really work with what you've got rather than just like going in blind. So,
Yeah. I think mine is probably just I'm a nurse too, so I use forceps a lot. So I forceps for me is like second nature. So I whether it's angular forceps, whether it's just forceps, um, because I use them throughout the process, different areas, because I just find it easier for me, I guess. So it's weird, but
so can I ask both of y'all, do you use forceps to suture? Because it seems like that would be safer. Like when like I think I said, I'm just like scared of stabbing myself when I was suturing that guy's scalp. And I was thinking like, forceps would be less slippery, and like a better grip than just having gloves on. But I was doing it like with hemostats to like really clamp down and pull it through. But yeah, do y'all know how to suture with anything besides your hands?
um, what do you say, Kayla? It's hard
I
because
honestly typically only use my hand unless if I'm really having like I can't get my fingers to quite grab it or enough through the skin.
Mhm.
Then I'll utilize an instrument to help finish pulling it through the skin. But for the most part, I just use my hands.
yeah, I'm kind of the same way. Sometimes I'll grab like a towel or a paper towel and I will use that with at the bottom um of the needle, suture needle.
Oh,
To,
to push it.
yeah, just to try to gain some leverage because I'm the same way. I'm not used to those big suture needles. So
Well, and
it
I find
takes me
like
a
the
long
S curve
time.
needle will just like twist in my hand or in my fingers as I'm trying to like put it through sometimes. So I totally understand that.
Yeah,
Do y'all prefer the S or the curved one, the C shape?
I do the S.
I was gonna say I've only ever done the S.
Mhm. We have both, and my preceptors are like, well, whichever one you like better. But I mean, I don't know enough to have a preference yet, like so.
I think
Um,
it's just because I can maybe get a little bit more control,
okay, yeah,
but
that's good.
yeah.
Okay, cool. I have a one of my sisters is an OBGYN and she does surgery like twice a week, and like surgeons just suture with instrument, like they don't use their hands at all,
Mhm.
so maybe I'll get her to give me a lesson.
There you
So
go. Get some hot dogs out or something.
yeah. Oh, funny. Yeah.
Uh,
Um,
what's next? Oh, pressure. Pressure rate of flow. What do you guys have for machines?
The Dodge 3 gallon. I don't know what it's, not that it has a name besides just Dodge.
We have the Porta Boy. So I
Oh,
just have pressure and I don't have a rate of flow setting.
Mhm.
I was gonna say the facility that I always work at, we have the Dodge, but some of our other facilities in the network have the Porta Boy, and I've never used it.
Mhm. It's kind
Um,
of a work in progress. Like our my preceptor, they like to start high. They set it at like, I don't know, 80 to 100. And
oh
then
wow.
um the other dial they set at like 40. And so when they open it, it's like, anywhere from it depends. Anywhere from 20 to 40, depending on what they have. Hmm.
We do
When
it really low, like between 10 and 15.
I was
Really?
gonna say when I'm not injecting the head, I'm at about 45 to 60 and a rate of flow 10 to 15.
Hmm.
Um, but obviously turning that down when it comes to injecting the head.
Yeah.
It's interesting how every facility is so different. Like we literally are all across the board there.
Yeah, it's so different.
Mhm. Is
Yeah,
the
and
question about pressure and rate of flow? Sorry, I'm not looking at the prompts right now.
yeah,
Yeah.
so it says, what settings do you prefer when you embalm? That's all it
Oh,
says
okay.
when you're talking about pressure and rate of flow.
Mhm.
I don't know. I guess mine is just kind of, I mean, it's what I know because that's what my preceptor has done, but it's just kind of like a happy medium to where you have a little bit more control over it. Um, I feel like going higher, I may get a little bit more nervous, but like I said, that's just, it's what I'm used to.
Right.
Um, let's see. So, yeah, so 10 to 15. And then, yeah, for pressure, I feel like we go pretty high,
Mhm.
like 120, I want to say.
Oh wow, you go clear up. Yeah. So
Does
our
that seem right?
yeah, ours
I'm
kind
trying to look at my little embalming report and see. My gosh. Sorry, I won't look at that. For some reason, it looks like it opened every single PDF I've ever used.
of yeah, so if we set the porta boys, it's been because of course half of them in each funeral home, one vial, one dial, not vial, does not work inevitably. And he's like, "Oh, you just move it a little bit." So, yeah, usually one is set like 60 to 80. Um, and then you set your other and so typically you're at like 40 to 60 when you open. But I wish we had just one machine that was different so I could set a rate of flow and things just to see how it worked, but maybe in the future.
So how does the portable way work?
So you have you set your pressure. So it would be your potential pressure. And then you have your other dial is um they don't call it rate of flow.
Wasn't it that you can buy an external
Yeah, you can buy an
attachment for
external.
rate of flow?
Hmm. And then so then when you open it, that's when your pressure gauge drops to whatever your actual pressure is at that point.
Right.
But then you can, as you're flowing, you can turn it down and up um, if you need more or less.
Mhm.
But but yeah, you don't actually have like a rate of flow. You just kind of watch your tank. It's a little deceiving.
Okay.
Yeah.
So yeah, so like our for pressures, I finally got a thing open. Potential pressure 140, actual pressure 120.
Ooh. Wow.
So
You go big.
yeah, I guess. And I mean, like that's how everybody does it. So like all the director, like, like everybody sort of puts the knob just close to the same place. And like, so yeah, the pressure generally stays about there. And then the rate of flow does differ depending on, what's going on. And
Hmm.
yeah, usually they start very low just to make sure that it's like that there's enough like that you're in the right place and that stuff is actually going. And then like once it's obvious that like the cannula is working and everything is working, then they'll like turn it up, but not super duper high.
So this portable does show rate of flow and pressure control. It's weird.
And then did y'all say that you do lower and slower, both of those on the when you're injecting the head?
Hmm.
Yeah.
Hmm.
Yeah.
Uh,
Okay. Ready to move on?
sure.
The next one is talking about those corticosteroids, um, affecting embalming, best way to deal with them. So of course, yes, they decrease and weaken the cell um, membrane and can cause
They
embalming.
make them they make them impermeable, right? Like they make the surface of the cell harder to penetrate. Isn't that correct?
That's
Yeah.
their
They
understanding.
block the cell membrane.
Hmm. So, so one thing that's interesting to me, like you're supposed to do like the pre-embalming analysis, but like that, you know, so the funeral home that I work at is owned by a funeral director, and then his wife is like the operations manager, and she's very about like discretion and customer service and everything. So, she like doesn't she discourages people from like talking about how anybody died. She's like, like you don't really need to know that, like to her, I think it seems like foolish and like a breach of privacy or something. So yeah, so a lot of times, most of the time when we go in there, we don't know how somebody has died. Um, which, and then it's like, oh well, like if the death certificate hasn't come back yet, like
I was gonna say that
what
makes it hard too, because sometimes people just need to tell their story. And, so if somebody's been battling cancer for 10 years, number one, that's amazing. Like what a fight they put up. But it also is gonna make a difference for you in the prep room as well.
Mhm.
and so like if somebody comes in from hospice, then we'll know for sure, like because and a lot of times those are pre-needs or like the hospice nurse will tell us when we go to pick them up. But yeah, in terms of like what all the medications that they were on, like generally speaking, we don't have access to that. So
I think that'll be a challenge. Kaylee could probably agree too, just from being a nurse and then going into this is we've had
Having
that.
all the information to none of the information.
Yes, yes. And it's like, yeah, like there's been a couple of times when I've come up here and um I'll ask Mary Ellen, she's getting ready to retire. She's the funeral director, and then Brad, my preceptor, is the mortician funeral director, he's the owner. And um I'll say, well, what, because she'll be in the nursing home or something. I'm like, what happened? And she's like, I don't know, she died. And I'm like, okay, so like had she been sick recently? Like Gladys didn't just die, like. And she's like, "Oh, I think she had that flu bug going around." I'm like, "Okay." Just little things that I don't know. As a nurse, I'm in a struggle with that. I
Yeah.
am in a struggle.
Well, and then actually, in all honesty, thinking back to it, I feel like the removals that I've gone on with my preceptor and other people, like that's kind of how they start making small talk with the family to begin with, is like, oh, like, have they been sick for a while? Or, just because that also helps you gauge, like, has it been something where they've somewhat prepared themselves for versus like completely abrupt and, they're in complete shock, that sort of thing. So, I mean, I mean, there's multiple aspects to where that's actually helpful information.
mhm.
Right.
And one thing, I mean, like autopsies are just going to be hard anyway, right? Because they're like 6-point injection for sure, all of that. But like a lot of times we'll get the, body back from the ME and like they won't, their cause of death won't be determined yet, but we'll go ahead and embalm, like right away. So,
Mhm.
but we don't know like what kind of drugs they have on board, and tox can take a long time. So,
Yeah.
um, yeah, so.
Well, and that's with the corticosteroids.
Oh
The
yeah, back to the question.
pre-injection and co-injections are going to help restore that cell membrane. So, but I feel like, I mean, typically I've not done a lot of pre-injections, but typically I feel like we're always co-injecting when I'm in the prep room with my preceptor. So that would help counteract anything that they did have on board.
Yep,
Mhm.
I
And What,
agree.
what do you use typically? What chemicals are y'all using?
We use Dodge.
Mhm.
I was
Um,
going to say we're Dodge as well.
are you?
Mhm.
Yeah.
What about
We're
you?
mostly Dodge, but some Champion stuff as well. Like two people who I work with really like Trisan and
I was
other.
going to say we have one champion in our prep room and that's Dysan.
Mhm.
And really, I think only one of our funeral directors uses the Dysan.
Mhm. So is there like a cocktail that y'all usually use? Like we always use rectifiant, we always use restorative. We always use a shoot, I'm blanking on the third.
Uh,
We use Metaflow.
yep,
Yeah.
Permaglow and Metaflow are big ones for us.
Mm-hmm.
And then the rest of the cocktail just essentially gets chosen based off of kind of what they look like.
Mm-hmm. Yeah. Yeah. So since I'm in the West, it's pretty arid and we have hard water, so like most of the cocktail is easy to, like it's always going to be the same, for water conditioner and humectant, just because those two things are really important, even after like 2 days, people can be considerably drier than they should
Absolutely.
be. Hmm.
Do you do
So
waterless?
I've never done a waterless. Have you?
I so one of the funeral directors, because ours is kind of the same. My preceptor has ownership in 7 funeral homes, so I kind of everywhere. But
Wow.
the one that's close to me on the east, he's an old gentleman. He's like 70 years old, so he's been doing this for 50 years, and he does waterless every time. And it is like between 6 and 7 minutes and done. He's done. It's insane. But it's like 8 bottles of I wrote down at some point it's like 8 bottles of the um water conditioner, and it's very precise, but and it's messy.
I was gonna say I have never been part of a waterless at all, so I wouldn't even know where to begin.
Yeah, there's
What
pros
makes
and
it
cons.
messy? Oh, sorry.
I think well, one, it's because he's like 70 years old, and he's from the era where it doesn't matter to him if there's the drainage coming everywhere. And I think it's just because his his pressure is so high. Like his goal is he knows he can embalm that body in 6.5 minutes, and he just sets it the same every time. So it's just like a whole lot of pressure, so the drainage is coming out that much faster.
So do you do any of the like the delayed, like do you start injecting and then cut the vein sometime later, or do you open it up right from the very
He
beginning?
he just opens and goes.
And just
Yep. Yep.
it sounds kind of awesome.
It is like it's just like I've watched him do it like 3 times now, and I just kind of stand there and I'm like, "What?" It's it's almost intimidating.
Don't think you'll miss it.
Yeah, yeah, like it's a little bit intimidating. I think it would be great if you could perfect it, but there's so much like in my mind, I feel like I'm gonna have a panic attack because all that just happened and we're done. But
Well, lack of control.
yes, completely. I
What
would be
happens if you have,
terrified.
yeah, so like with the pressure so high and going so fast, like did clots just get out of the way? Like do you
Like a
ever have to,
cannon.
yeah,
Yeah,
like
but he's so the whole time he's standing there with his angular forceps and just Yeah,
Hmm.
he has his apron on, and it is just, and that the so my preceptor says like he has the messiest prep room in all of the funeral homes.
So, but like thinking about, like sometimes where it's like one leg won't embalm, right? And so then you have to, in our case, then it's like, oh, we have to go in through the femoral in order to get this leg, because there's
Right.
some blockage that we don't know what it is that's keeping it from going. So,
And he'll do that.
okay.
And he does a lot of this last one I went and watched because I was driving through. He does a lot of surface packs too.
Mhm.
Yep.
Interesting.
Yeah.
So surfactant is corticosteroid treatment to
Yeah.
get the stuff into the cells so that you don't get a bunch of edema, swelling, right? Um, oh, anasarca, right? Is that the term? I
Mhm.
think. So yeah, from the stuff sitting outside the cells instead of going inside.
Mhm.
Sorry, Ryan. Just wanted to make sure we answered that question.
I know, yeah. We're kind of like all over the place, but that's okay.
It's a podcast for a reason.
That's right.
Yeah.
Yes. Yeah.
It's about sparking the conversation between all of us.
Hmm.
Right. Okay, how about our most interesting case so far?
Mine has been a gunshot victim. Um, I think there was a total of 7 wounds. This is the one that I was referencing earlier when I was talking about the tooth being on the tongue and how I couldn't handle it because it to completely shattered his jaw. So that was a full reconstruction. Um, and truly, like younger gentleman didn't look like, I mean, minus obviously having gunshot wounds leading to his death, like didn't look like really anything was wrong with him. And we, for the life of us, could not get him to embalm. Like some places you could see like obvious fracture in his arm. The other arm looked completely fine, and we raised everything trying to get that arm to embalm, and we could not get it to embalm. So it was something. Like I could not believe, and he was under 30. So it was just astonishing to me about everything that we had to do and everything we tried to do and still couldn't entirely successfully get him embalmed.
Hmm.
Man. What about you, Misty?
So um running out of time. Oh, we have 10 minutes left. Okay, 9 minutes left. Of course, small town, live in 1,200 people. So everybody knows everybody, and being a nurse, take care of everybody too. But I think so far it's been kind of a both physical and emotional. Difficult case was one of our ladies that I took care of many different times at the hospital, a little 100-pounder. She had had a triple A that we found randomly. She was having stomach pain and sent her out, got it fixed, and then she was back in our hospital, got was doing fine with therapy. She ended up hemorrhaging on us, got her back out, fixed again. She was at home doing wonderful for over a year. And she fell, hit her chest. Everything turned out fine, like her scans and everything. 2 days later, she passed in her sleep. So, fast forward to that morning, Brad, the mortician, and then another funeral director were coming to embalm. So I was going down. Um, and anyway, by the time I got there, nobody really knew that history very well. And so the other funeral director had started to embalm her, not knowing that she probably had a disruption of the aorta again. And he had basically blown up her head. It just completely went, all the solution, it just bypassed and went right to the head. And that was honestly probably the most difficult because then, of course, when Brad got there, we ended up raising everything. But a lot of that fluid did not come back out. Um,
Oh,
we tried the weights, we tried, the fluid and surfaces, and which it was only going to be family viewing. They were very strict Catholic and they did not want an open casket, but it was so hard because she was a beautiful lady and beautiful white hair and um I don't know, that was the toughest. And I know that sounds weird, but that was the toughest for me. Just did not work as nothing worked right. Nothing worked right with that embalming.
Well, and it doesn't help that you also had that connection to her prior,
Right.
and you're trying to also give the family their final closure. And you're like, I know what she looked like, and this isn't it.
Yes.
And you just know that that's the hinder, or that is a hindrance as well. So that makes it more difficult as well.
Right.
Mhm. Yeah. Um, I would say my most interesting case was the first autopsy that I worked on. And so it was interesting just because I had not seen an autopsy yet. Also, injecting the head was really interesting because of the circle of Willis, like the fact that you can actually see all of those cut vessels, and like leaving the scalp down and then like
Mhm.
very carefully lifting it up, being out of the way to see like where it was coming out into the skull and then clamping that with the hemostats and turning the pressure or the machine back on to see if you got it, So all of that was very interesting. And then also, this woman had breast implants. And so, like we put them back in, like she was open and we carefully took them out and set them to the side. And then when we were suturing everything back together, we like put them back in where they were supposed to go and sutured so that, she just like everything was back together. So all the whole thing of it was really interesting. Um,
Yeah, that is interesting.
I was
mhm.
gonna say that's not even something I've ever even thought of, is the fact of somebody having breast implants and them having an autopsy and having to put them back in.
Yeah, yeah, it's pretty nuts. So do we have another question?
Um, Kayla, did you answer? There's like 5 minutes left.
Oh, sorry.
Um, well, I was gonna say, I guess I can go more into that gunshot victim that I did talk about, actually ended up being shot from behind, and he had entrance and exit wounds throughout his back, chest. Like I said, his jaw was entirely shattered, so that had to be reconstructed. And that alone just was something, I mean, partly interesting, what I could watch anyway. Um, and then so like the reconstruction of his jaw was, like I said, it was interesting, and it was, I guess, something that you think about, I guess, as a normal person on the street. They always talk about how, the people in the operating room, they use the same tools that, the construction worker does down the street. Well, welcome to the prep room as well. So,
Yeah.
um,
Did he look
but truly,
okay, like the for presentation?
what?
Did he look okay, like as far as presentation to the family?
Afterwards, he looked amazing afterwards.
Wow.
I mean, crazy what we can do in the prep room, or, my preceptor can do in the prep room. 'Cause some of that stuff, it's like, okay, I'm standing back and watching because I don't want to mess it up worse than it already is.
Awesome.
So, but it's just a matter of, especially dealing with all those entrance and exit wounds and suturing them. Obviously, one being on the face, so that you're going to take different care of that versus what you are on the, like his back and his abdomen, because you want to reconstruct him and make him look more natural. Then, that's just, in a sense, the family may know it's there, but it's still traumatic to actually visually see what your child went through or what your loved one went through.
Yeah.
So.
Yeah. I can't imagine.
Yeah, I can't either.
That was truly a very, very tough and interesting case for me. Like, I don't care what this person did. He did not deserve this.
Mhm.
Like, that's awful.
Yeah.
Mhm.
Okay. Well, is there anything else?
I don't think so.
So,
Okay. I'm
Yeah.
gonna stop recording.